Welcome to our series of healthcare scene interviews where we sit down with top leaders in healthcare IT. I'm John Lynn, the founder of healthcarescene.com, and I'm happy to host this amazing group of healthcare data experts. Before we begin, I want to remind those watching live that we'll talk for about 40 minutes, something like that, and then we'll open up for questions for you from the audience. We may try to include your questions during, so feel free to submit them during the video interview as well. And for those on the lab watching live, you can like someone just by clicking on their face, and that gives them props if you like what they're saying, or if you just like that person, feel free to click on their face. Also on the left side, there's Tell a Little Bird or Tell Your Friends, where you can share this on Twitter, on Facebook, and do that. We appreciate everyone that shares what we're doing so that more people can join live and make a better conversation. Mandy's already excited about the props. Finally, if you have a question and you're watching live, you can put /Q and then space in your question, and we'll see that. That will add it to the question queue as well. So enough with the housekeeping. Let's get started with the some intros from our healthcare data nerds. I affectionately say nerds. That's a compliment to everyone here. Let's start first with Mandi Bishop, Health Plan Analytics Innovation Practice Lead at Dell. Mandi, Tell us about yourself.
Well, goodness gracious, what do you want to hear? So I've been playing around with my computer since I was 9, but I do not have a degree in anything remotely relating to healthcare analytics. So I have always been a computer and a data geek. However, I am only about a 15-year convert to an IT professional. But I absolutely love and adore working with health data, working in the healthcare IT space, because the opportunity to impact everyone that I know and love on a regular basis and to have a tangible impact on the world around me is something I wake up, have to do every day. So on a personal note, I just got married. And I just got married, and I live in Jacksonville, Florida, where it is currently almost 80 degrees in mid-December.
And your day job now is the Health Plan Analytics Innovation Practice Lead at Dell, which basically means you roll around in health data all day helping Dell's clients be successful. Is that right?
I do, absolutely. So I do a lot of work with our health insurer clients. And now that there's a lot of market convergence between healthcare payers and providers, I advise to ACOs and new value-based care models, reimbursement models, alternative care delivery methodologies. It's a lot of fun.
Excellent. Thanks, Mandi. Welcome. And next up is Ashish Patel, co-founder of careset.com and docgraph.com. Tell us about yourself, Ashish.
Okay. Can you guys hear me?
Yep.
Yes.
Excellent. So thank you, John, for inviting, and Mandi for putting this together. So I'm very happy to be here. I'm an industrial engineer graduate from Cornell. 15 years of experience doing data analytics across a number of different industries. Started out in network security at VeriSign. That's actually where I met Fred Schroeder about almost 15 years ago. And he was a senior network security engineer at VeriSign, and I was a lowly analyst. But as a lowly analyst, I was fortunate enough to read most of the HIPAA legislation as it related to data governance. I helped co-author the HIPAA data governance audit document for VeriSign, which we later used in a bunch of different hospital settings. As a field consultant, I've been able to work to look at lean processes and wherever data can inform feedback or data can be used to inform a larger audience, usually in a consulting role, helping extract things from data. As a statistician, I'm very fond of time series analysis and doing kind of state table based analysis, which in healthcare is a fairly new type of science. I think that there are pockets of it all over the industry, but there's so many individual pockets within the healthcare industry. And that's over the last 4 years, I've been able to work more closely with Fred. I mean, we partnered up, had started DocGraph, and then started CareSet to really understand all the different pockets of data that are available.
So I have a fun story about Ashish and Fred really quickly before we move forward. So Ashish is like king geek. I'm really thrilled to be in the same internet space as Ashish and with Fred. And Fred Schroeder was one of the very first heroes of mine who I happened to meet in person. And this was at Strata RX, the inaugural Strata RX in October 2012 in San Francisco, California. And I kind of stalked Fred throughout that conference. And this is where Fred had just released Hacking Healthcare. He had just released the O'Reilly book. And he got up on stage at Strata RX and was giving away USB drives that actually had the CMS referral data set. So the very first open data set that CMS released, Fred Trotter had, and he gave them away throughout the conference because he wanted everybody to do stuff with it. And a fun fact, I still have that referral data set, and I still use it to do just to continually familiarize myself and then my daughter. And as I try to have conversations with people about what open data can do for you, I always use that original USB drive that Fred gave me at Strata RX in San Francisco. So fun fact.
I was cleaning out boxes at my parents' house over the weekend and found 4 of those thumb drives just a couple days ago, put them in the computer to verify, because we had original versions of our licensing and things like that. Things, when you're doing a startup, you have no idea what you're actually doing. And at Strata in 2012, we barely had any idea, but that's where everything sort of launched for us, because we did it in conjunction with our MedStarter crowdfunding, which was incredibly successful, which was the cue for all of us to go full time and really nurture the DocGraph audience, the ecosystem of data scientists there, learn from them, and then all of that ultimately begat CareSet. So.
Awesome. And a shout out to Alex Fair of MedStarter. So thank you, Alex, because I know that you've done a tremendous amount throughout the community to help fund a lot of these types of initiatives that have allowed our heroes like you and like Fred, Ashish, to continue to move forward in your work and have make an ongoing mark in the world. And I'm awesome. I'm so excited for Alex.
I think you guys came in with like a nerd level of 10, but I think you just took it to like a 20 with, your favorite gift is a USB drive full of data, right? So that's what we want, right? That's why I wanted you on this blab is, and I think Ashish hit the point, right? That there's all these pockets of data throughout healthcare, and we're seeing data used in all sorts of, such a wide variety of ways. So, Mandi, why don't we kick off some of that discussion? Where are you seeing data being used most in healthcare today?
Well, I want to talk about the types of, so typically my involvement starts on the health plan side, right? So right now, my typical client engagement is with an insurance company, with a healthcare payer. And their world has been, up until the last couple of years, has been claims data. So everything about the health insurance organization revolves around the claims data. And it's only in the last couple of years that they are waking up to the opportunity that all of these additional data sets bring to the table for them. So they're starting to understand that the provider data and the encounter data that is now being produced as a result of meaningful use might be worthwhile for them for care management, disease management, utilization management processes. So they're finding new opportunities in health data sets and also realizing new opportunities in data sets beyond what's traditionally considered healthcare. So the concept that life is health and that all of these other dimensions of one's life have a significant impact on your actual health. Your retail spending habits are one example of data that's tremendously valuable that both payers and providers are starting to take a look at. Understanding geographic movement patterns for families, like where are families vacationing, where are families moving, how far away do families live from their workplaces? Like those types of geographic data points are becoming relevant in discussions about health. So that's a really exciting conversation to have, is watching the light bulbs come on and people's eyes open as they realize the opportunity for all of these new data sets. And then there are a lot of opportunities for data sets and new insights with existing data sets and the claims data that they already have, which is something that Ashish and I have been talking about quite a bit and really excites me as well.
Interesting. Ashish, you want to hop in there? What are some of the things you're working on?
So what Mandi was talking about, that GIS or geospatial interpretation of information,
right?
It's a critical part of the story, right? So healthcare is supposed to be hyper-local. If you look at health plans that are ACOs potentially turning into MA plans, they're all hitting a rigor of network robustness. So they have to be able to verify that their average distance between their providers and their patients is below a particular threshold. That means there's a ton of geospatial calculations going on. And then as an industrial engineer, one of our classic rubrics of analysis is traveling salesman, which allows us to understand the various paths that can be taken or executed between two different points. But traveling salesman is effective when you understand the path, where what we spend a ton of our time obsessing about is the path patient takes through the healthcare system. But that path has all of these tangential or anecdotal, I would say, confounding variables. Very technically, they're variables that are affecting that path that no statistical model has represented in its various factors. So a statistician would think of this using a paradigm called 2K factorial, for example, to help understand the exogenous variables and the importance of those that are affecting that path for the patient through the healthcare system. And that's what I'm spending a ton of my time pulling together different geospatial or independent kind of discrete data sets that talk about transactions inside a health system and trying to put the patient in that story so that we can treat them less like a pinball. Like that's my greatest, what's driving me is my parents have been treated like pinballs. Fred's family's been treated like pinballs. Everybody's treated sort of like pinballs being paddled around the health system. And that's not necessarily a good experience if you've ever been a pinball. And we're really trying to optimize that and make it a soft landing for everyone who enters and a real quick exit for everyone who can exit.
Right.
So we spend a lot of time thinking about that.
And so the geospatial is a new realm that so many of the people I talk to every day had not yet considered. I think everyone in the abstract understands that it's important and that it's something that might play a role in healthcare and outcomes. It might play a role in cost. It certainly plays a role in care coordination activities, right? Again, all these geographic factors. But very few organizations have actually been looking at this systematically. So we're starting to see a shift in, from a very narrow focus on CPT codes and ICD codes, right? We had all been very, very focused so narrowly on the reimbursement mechanisms and on the diagnosis mechanisms that we hadn't taken a look at what all of these additional dimensions might bring from an insights perspective.
So were they just so distracted by the other data, or there was just so much value to be had from the other data that they never got to the geospatial? Or is it the geospatial is not as accessible or wasn't as accessible?
Ashish, you want to take that? I think that for the most part, they focused on reimbursement first, and that was anything that directly impacted reimbursement. But Ashish, if you've got a shot.
I think my theory on this is that the analytics tasks are handled serially, and the entire industry has looked at the actuarial approach or the actuarial utilization of data for like kind of what Mandi was talking about, utilization in the financial models. And so the analytics teams in all of my clients have been really they are professionals at the actuarial models, but these kind of knew the edges of where the actuarial meets kind of, I guess, street knowledge, really like what's actually happening with the patients. And I hate to keep using the metaphor, but the pinball approach our pinball, thing that happens to people is now the data analytics teams are splintering so that some of them are able to go and look at platforms that can understand the geospatial relationship between the providers. And I know the topic overall is kind of new data-driven perspectives, but one of the key data sets here is NPES, the NPI database, and that gives you, mailing address and practice location of physicians around the country that are billing government plans. And in most cases, a provider has to have an NPI number in order to bill any kind of plan whatsoever. So everybody's in there. So if you want to kind of, hack on this yourself, NPES is routinely updated by providers themselves with their own contact information.
Sure. One NPI. Is one NPI ever enough?
Well, NPES has 1.7 million records, or I probably, the Twitterverse will correct me because I haven't checked in a while, but it's got everybody's NPI, right? It's pretty significant. Organizationals and provider.
Yeah.
Interesting. Well, and that goes back to data quality, which I think we'll hit on a little bit later. But so what are some of the things Ashish is spending a lot of time in data. Mandi, you're spending a lot of time in data with your clients. Like, what are some of the new things that we're discovering as we start to dive into this data? I mean, you've highlighted the kind of pinball experience, which I imagine when you pull up the data, it's probably even worse than you expected maybe, or, what are you finding?
I want to talk specifically about an example that Ashish brought up, and Ashish can go into detail on it, and kind of prompted this call, right, and this mix of topics. Ashish and I were talking about the referral networks, right, and understanding the referral patterns within like an ACO environment or with any type of accountable care or an MSSP or an MCO, managed care organization. You need to be able to understand where your primary care physicians are referring, which hospitals are referring to which specialists, which hospitals are referring to which PCPs. Like, you need to understand how doctors and hospitals are referring to each other in order to maintain or monitor the performance of your accountable care organization or managed care. And Ashish mentioned that he had done alternative referral pattern analysis, not with that goal in mind. So not looking at the reimbursement methodology and not looking at the network, a narrow network definition, but looking at it from a familial perspective, right? So are there family members, there are families of physicians who are referring to each other? Are there ethnographies or ethnic groups that are referring consistently to each other? And so that prompted for me a whole new level of understanding about dimensions of referral patterns that we're not looking at today, and that would factor heavily in potentially outcomes and cost, and that are, but we're not applying that lens to the data yet. So Ashish, yeah.
Sure, that's sort of a layup. Thank you, Mandy. So we did an investigation for a particular East Coast market where the health plan was having a lot of trouble penetrating a particular market. And what we discovered was that there wasn't, the health plan was looking to augment its network based on which provider would pose the least risk from a leakage perspective, so that the provider was most aligned already to the existing network providers, the other doctors in the network. But then we found that there was no way for this particular part, the Chinatown neighborhood specifically, for that health plan to be able to adopt new physicians and not leak, because the Chinese-speaking community in this particular town refers patients in and amongst each other because of that cultural backbone that exists, and that breaks the health plan model, right? It goes across the ACO, it goes across multiple payers, it's actually very patient-centric, and it's optimized for a patient experience. And then I've done the exact same thing here in Houston, where I live. And I'm Indian. My parents, my father has a lot of turmeric for his blood pressure, so he needs to have a physician who's also Indian who understands some homeopathic qualities of food. Mm-hmm. And so then that limits his network. And then even further, as he moves from one plan to another, and he needs to move 10 years of medical records from the HMO to the PPO network of the same payer, we end up finding, subsetting the plan down to the Gujarati physicians who are also running, I think it was eClinical, right? So that we could export the 10 years of data that one physician already had who was in the HMO. And then now that my father's in the PPO, we had to move that all eClinical. So I had to find a Gujarati physician who's running eClinical. Fortunately, his son is sitting on all this data, and so we could make that transition really easy and happen in a couple of days. But it did take me even a couple of days to figure it out, and I had all the answers.
Right.
So we're in a position now to build tools to try to make that patient experience easier and accessible for the 65 plus who's trying to figure this out on their own, which is just, I can't imagine, right? With all of the answers that we've been able to amass, it's still difficult.
Well, and so I want to use my grandparents also as an example to build off of what Ashish was just saying about, we give a lot of lip service as an industry to being patient-centric, but like Ashish was saying in that, these community examples that truly are, that the care coordination truly is patient-centric in those particular examples, and it's not governed by the reimbursement methodology that these providers participate in. It's definitely guided primarily by the patient. So my grandparents, who are kind of familiar to anybody who follows the health standards, right? Like my grandma can read her CCDA. She actively participates as the care coordinator for she and my grandfather, and he's 93 and she's 90. But unfortunately, my grandfather has dementia now, and my grandmother recently fell and broke her hip. And that's that is usually the precipitating event that can indicate a health decline and ultimately does not have a good long-term prognosis, right? But Ashish was able to take a look. Between the two of them, they have 17 doctors, and this is in Ohio. And Ashish was able to leverage his data set to go in and take a look at what EMRs all those doctors have, and we could determine the likelihood of being able to get their complete medical records from each of their participating doctors and facilities, and look at nursing home facilities, skilled nursing facilities, to determine where would be a good where has high quality treatment, right, based on the outcomes that he's seeing, and also where could we have kind of a seamless or as seamless as we can get record reconciliation. So being able to take being able to take the medical data and apply it from a personalized standpoint at the patient level to use for those types of scenarios where there is ultimately a care coordination activity that needs to happen. There's a transfer that needs to happen, but that's patient-centric medicine. That is a patient-centered medical home. That's the model that we need to be able to get to, but we're not yet using the data effectively enough from a patient-centric point of view. We're still using it from a plan-centric point of view or a provider-centric point of view. But, Ashish, I was so grateful to him for helping me. And thankfully, we were able to find a skilled nursing facility nearby and attached to the hospital where they, where they were, where she was already being rehabilitated for her hip. But it's, those scenarios are where all of these dimensions of health data come into play and can be incredibly valuable to the patient, rather than to the plan, rather than to the provider, but ultimately to the patient.
But it sounds like there's still some more work to make it usable for anyone. I mean, not all of us are lucky enough to have friends like Ashish, right? So, I guess that's the next stage of the data, is kind of making it accessible to everyone.
Ashish,
absolutely, right? So, so the purpose of data is, I feel like data is a kindling, right? And every company is creating a whole bunch of it, but they may not be actually able to leverage the fire that they've been able to build. And only once we are able to build a furnace can we make a steam engine, right? So we're at the point of trying to architect good furnaces. We shovel in a ton of data, but we're not producing the right result. It's kind of spark and then the engine dies. So like we're really creating a bunch of different motors. I think all over the healthcare industry, people are trying to understand how can we ingest and treat data like coal and produce fire or electricity, something of a widespread utility. I think that's kind of the state of various camps. They're trying to understand the utility of their data first and test it. And Mandi and I are able to do so, we're sharing our own personal experience, because we're on the fringe of both having the data and being the engineers of the furnace, right? And and where the electricity actually is consumed, it's actually by the patients and the entire patient community of the healthcare system at large. But there are a lot of engineers that are building lots of individual furnaces. So
right.
I think that's kind of where we're at.
Well, and to think about a more imminent use case, right? Something that is on the horizon, and some health plans and some providers are using this information today. Let's think about like social data, and leveraging social data to inform your individual engagement that you might have with a patient or with a member. So if you're participating, if your patient has agreed to provide you with their social information, their account handles and whatnot, and you participate, or if they call in, so say I call into my health plan, they would have an understanding potentially of any life events, major life events that had taken place. They might have understanding of if I've been complaining of any type of symptoms recently. You would have a much broader understanding if we were able to take that data and ingest it and have it available to enhance their experience for customer service, for care management, disease management. Again, all of those processes could be augmented and enhanced with additional data that's already available, and that's happening now. So it's kind of slow to adopt because there's still this tremendous fear of privacy concerns. But the methods and the meanings that could be derived, especially from the social data and the retail behavior, that's already happening. I'm seeing that happen in the marketplace. But I love Ashish's analogy of coal, right? Of data being the coal and us being able to produce some type of energy from it, and that energy to be consumed by the patients. That's the goal. I love that. Ashish, I'm going to use that. Can I steal that? I'll attribute it to you.
Sure. No, I use it all the time to describe kind of the relationship between DocGraph and CareSet, where DocGraph is sort of mining coal and CareSet is producing electricity, right? So our clients, the CareSet's clients don't have to mine coal. They actually can go directly to Insight. And that's my plug, so I won't do any more of that, right? But, sure.
So let me play devil's advocate a little. I mean, I'm sure a lot of people, when they hear about all this data, there's always the question of security. There's a question of how will the data be used. And, I mean, in any economic model, leave it to someone else to corrupt anything that could be used for good, right?
Right.
There's the evil parts of society that want to use data to discriminate against people that, maybe are the most vulnerable patients, or, to discriminate against cultures even. You talk about it in a proactive way that it's a benefit, but, it could be used in the other. I mean, are there bad uses of healthcare data, and how do we protect against that?
Yes, I often wonder, and I ask this question frequently when I'm speaking to analysts and others about population health. And as I think about population health and as I think about accountable care models, and so Steve Shannon, this might get to your question, I often wonder what population are we effectively monitoring and managing, right? So as we become better and better as an industry at coding, and we continue to drive coding methodology to suit reimbursement models, we're continuing to keep our focus on the financial. And I understand that there need to be financial drivers in order for this industry to succeed and thrive, right? I get it. We have to address the question of dollars. But at the same time, when all of our effort is spent trying to create and capture data that serves the primary purpose is for reimbursement and to maximize reimbursement, I really don't know how accurate you can take that information from a clinical standpoint. So that's always been my concern about health data and about the emphasis that we're currently placing on, only on the reimbursement methodology and outcomes. Even, I know that from a value-based care standpoint that we have outcomes measures, but quality and outcomes are really measured by how many times did, this diagnosis, which equates to this particular code set, has to have this test performed this number of times. Okay, well, something in the case of like beta blockers, for example, the Asian population can't handle beta blockers the same way that a Caucasian population handles beta blockers. So it's actually detrimental to the Asian population's health for them to have beta blockers, after cardiac events. And yet that is a protocol that's required in order for you to meet quality measures. But those quality measures are harmful to subsets of the population. And so those types of kind of global standards that aren't taking into consideration personalization and precision medicine, right? I mean, this is where those initiatives need to come into play and need to be adopted sooner rather than later, because this continual focus only on reimbursement methodology from a unilateral standpoint is not going to be effective in helping anyone get healthier. My 2 cents.
The reimbursement methodology and I think the analytics that surround it are a very mature science, and they're still progressing there, but it's a fairly mature science. And what we were talking about earlier was kind of geospatial and consumer data affecting that, or maybe even Fitbit data affecting that. These are all fairly new sciences, and an AI engine or a decision support system or could be riddled with errors due to exogenous variables that we are not appropriately weighing in our model. Right. So all the engineering teams right now that are trying to do something new will probably have a system that produces a type 2 error, or a false positives, and a series of false positives in this industry can be
deadly.
Yeah. So that's the real big warning label on data analytics, right? Is that having a high level of confidence in your data, it really correlates to high N, like population count in the data that you're actually pulling in. But then also you have to make sure that your cohorts are properly identified. So Mandi was saying the Asian population, and I earlier was referring to the Indian population. The anecdote for Indian population is that they will take a lot of dietary supplements that are not necessarily FDA approved. There'll be a combination of Western and Eastern medicine practiced in every home, right? And so our models of our physiological models that we're designing right now may not account for that subtlety. And so that's, but still we're very much on the drawing board. We're in R&D. These are machines that we're trying to invent and make robust, because the actuarial sciences are fairly mature. And if data analytics is approached serially, then this is the brink, and this is where we're able to focus, because the previous work that we've already been working on for 20 years is a really mature science. The data teams can move forward.
You know, it was an interesting, you bring up such an interesting point about healthcare data, right? That if you get it right, you're going to save a lot of lives and you're going to improve a lot of lives. But if you get it wrong, and even just a small percentage wrong, some people are going to die because of the data science as well, or they're going to have a worse life, or whatever the impact may be. And I was having a discussion recently with someone, and really we were talking about it kind of in the Watson-ish type technology, right? In making these things smart. And someone commented to me that Watson only needs to be smarter than a human. It needs to be more efficient than a human, right? And it needs to save more lives than a human. And as I thought about that, I realized, is that true? And I started to question, like, for some reason, we expect computers to be perfect.
Right.
We expect perfection from our AI technology, and if it's not perfect, we can't accept that. Oh, let's get rid of it completely. Whereas with humans, we understand that we're imperfect, and we're okay with doctors being human, but a Watson-ish, like, data-driven doctor is not allowed to be human, right? Like, even if it's better than the human equivalent and the human replacement,
right? For
some reason, culturally, we're uncomfortable with that. It seems like that's the challenge we face as we enter this is changing that perception that our data needs to be perfect.
Yeah, I think, and it's not just that the data needs to be perfect, because I am a huge proponent of data quality and of the lack of data quality that we find in healthcare. So I don't want to, by saying the data doesn't have to be perfect, I don't want to imply that we can continue to accept the level of poor data quality that we have in the system right now. But I think you're right. I think that there is this expectation that no other computer-assisted model, no clinical decision support, none of these other paradigms are going to be good enough because they're not perfect. But unfortunately, we program them, and we are human, and we are fallible, and we are not capable of thinking beyond our experience. I mean, we really aren't. There are some people who are just leaps and bounds beyond what I can imagine. But we're still limited by human experience, and we are imperfect beings. So for us to be able to program something that could ever be perfect and could consistently result in and have perfect results, I don't think is feasible. I love the data quality be higher.
Okay, it may be better, but it may not be perfect.
Right.
So I think right now we're at the echelon of suggestion systems and not allowing a system to make a decision.
Yeah.
There's decision support.
Right.
And so they're fundamentally perfect for reminding us of things, right? Hey, you've done 7 of the things in this particular series of events, and don't forget number 8, 9, and 10.
Right.
Right. And right now there are 20 companies that I know that are amazing that are doing these kind of reminder systems that are really data driven. They're pulling in our behavior information or maybe what's happened to us inpatient and outpatient, which is kind of the realm that we're looking at is, okay, this particular patient has done these 9 things in the system, but we know in general an arc through the healthcare system goes 22 steps, right? For a particular type of an arc. This is kind of bundle payment methodology stuff. So we know that to kind of have an ideal outcome, that patient's going to do these other 13 steps in this order. But these are all suggestions. These are suggestions for the care coordinator or somebody who's interfacing with the patient directly to help them make sure they're doing these steps, which are highly correlated to a positive outcome. Right. And that's where we are right now. I think that's a fairly good place to be. I think that's a fantastic place to be for quite some time. We don't need the systems to start making decisions for us.
Yep.
Yeah, I think that having the humans review decisions is definitely important. But thinking again about the things that the machines are programmed to factor into their calculations. I was on the board of advisors of an organization called Surgical Momentum for a little while, and they were doing clinical quality innovations. And Dr. Bruce Ramshaw was the CEO of Surgical Momentum, and he specializes in hernia surgery. He's an amazing general surgeon. I think that he was the president of the American College of Surgeons for several years. But things that mattered to him and that he determined mattered for surgical outcomes are not data points that anyone is capturing with any degree of regularity. So things that mattered that he found in his practice were like the position of the patient on the operating table. So if a patient had been strapped down with their arm in this position for 12 hours while several hernias were repaired, they had X different deviations in their outcomes. The type of hernia mesh that was used had Y number of deviations in their outcomes. The size of the hernia mesh and the difference between the size of what was ordered and the size that was cut down and actually implanted, the type of sutures that were used, like all of that level of detail, and not using it from a CPT standpoint so that you can be reimbursed for those materials, but thinking about it from the human standpoint, like how many punctures did you have to create in this human being in order for you to effectively finish the surgery? What other factors? And he did a lot of behavioral analysis before surgery. He wanted to understand the patient's state of mind. So he actually he did very comprehensive mental health questionnaires. He wanted to understand their family situation. He wanted to understand their state of mind going into the surgery and then coming out. And he had counselors available so that he could assist them emotionally with the recovery process, and that he could help the caregivers. So all of those dimensions of information he found to be impactful, and we found through our analysis that they were in fact impactful to varying degrees with different populations. But to Ashish's point earlier about not having the patient cohort, and not having it was a very small. We were only able to experiment with the patients within his practice, right, who allowed him to do this type of deep dive into their familial situation, their financial situation, allowed them to capture the data points around their surgery, everything about the time of their surgery. Was the doctor late? Did the doctor show up on time? Was the doctor late? Was anything delayed? Was the room ready? What temperature was the room? Like all of those types of detailed information that we don't currently factor in, and they aren't part of our model. So Watson doesn't have that. Watson's not thinking about it because we haven't told Watson to think about it.
We don't capture that, dude.
Right.
Yeah,
but it matters.
I was referring to exogenous variables. They're not in our model, right? We know that they're affecting outcome, but we don't know how to plug them in with an N that's high enough so that we can adjust the model appropriately, and the model can reliably receive that type of input on going forward. So we can evaluate prospectively rather than retrospectively.
Yes, absolutely.
Interesting. So, we're wrapping up our time, unfortunately. I think we may have to make this a quarterly visit or something, but there's so much more we could talk about data. But, kind of to wrap things up, I'd love to hear, in your dream world, what would you love to see happen with data in healthcare? Either what new data sources would you like to see, or access to data, or the way it's processed? What's your dream data source? And then after you answered that, we'll wrap up this for the YouTube audience and the recorded version, and then we'll open it up to the live audience for questions. We can have other people join in as well. Ladies first, you want to go, Mandi?
Yeah, sure. So first, I would like seamless data capture. I still want my doctor to look me in the eye. I want my clinicians to look me in the eye. When I am, when I'm having to go to be seen, I want to be able to have a conversation. And I think that for them to be able to capture information about our visit seamlessly without having to spend my visit with their head buried in a screen, that's step one for me from a data perspective. You got to be able to seamlessly capture the information. I would like to capture far more contextual information, the exogenous data points that Ashish was talking about. I'd like to be able to capture all of the meta information about that visit, in addition to all of the reimbursement, details that are required for coding purposes. Downstream, I would like us to be able to incorporate. I want to be able to incorporate these deviations in types of populations. I want to first be able to study and understand how do we differ, because we differ on an individual level, right? Our genes are different. Our genotype and phenotype is going to determine how we are going to react to different treatments. So, in the future, I really want to understand how advancements in genomics and phenomics are going to make a difference in determining appropriate care paths and treatment plans for me. So those are my two biggies, I think.
Excellent. How about you, Ashish?
So part of my dream data list, unfortunately, is IP, and it's trade secret because we're working on that. We're working on producing and making those dreams come true for everybody.
Go Ashish.
But yeah, I'm really particularly keen on seeing HL7 standards appropriately implemented across EHRs. I think that would be an amazing dream, right? Because then
Dream on. Dream on. Dream on.
Mandy, when one of the first longer conversations I had with Mandy was her telling me how she had consulted for a health information exchange somewhere, and how she was intimately familiar with how different CDA had been implemented across multiple different EHRs.
Yes.
And I think this was part of one of the conversations that re-indoctrinated me into the operational side of healthcare. And I began seeing exactly how different implementations were myself and how uncomparable data sets are. So if we're really talking about, ONC's proposing, we're in year one of a 5-year roadmap on interoperability. One of the fundamental steps is unilateral implementation of open standards. So that's a dream. Hopefully that's not a real
just
dream.
Implement the standards that we have today properly. Is that your dream?
Yeah.
Uniform implementation, because then you'll be able to get ends that are high enough in order to do this. And then if meaningful use is implemented appropriately or uniformly across a fundamental base, whether that's Argonaut or Commonwealth and the constituents within both of those camps are doing this, whoever does it will then be able to add on these exogenous variables in a structured manner, so that we're building systems that the data model is a learning data model. So if you have a core data model that's misimplemented across multiple EHRs, then you can't even have comparability or an AI system or a decision support system that sits and ingests data from multiple different EHR vendors. So if we can't do that, well, we can't really have the next conversation. And as I was saying earlier, data analytics is fairly serial. So we have to have mastery or some fundamental comfort with what we're working on now in order to move on to the next more complicated piece. We can't have comparable data from medical records, but comparable medical records if the medical records are fashioned fundamentally differently.
Yeah. Well, and on that point, so just again, from a dream world, right? From a process perspective, because it all starts with process. We can have interoperable systems. We can get that, my favorite Fritzma's high jump of interoperability. We can actually have semantic level interoperability across all of the CCDA implementations, across all of the EMRs. But without fundamental understanding of the clinicians who are actually entering the information into the EMR, like without them understanding the importance of the information that they're putting in, and how it can impact how the completeness of the information, like please do medication reconciliation with all of your patients. Please have that conversation with your patient about whether or not they're a smoker and really understand their family history and really document it. Like without the same level of consistent application of the process to capture the information that would actually help us have more meaningful impact on outcomes and cost, all of it's moot. We can have the best data in the world, to play with from an analytics perspective, but if it wasn't captured, if it was captured haphazardly, or if it was, the deviation from clinician to clinician is extreme from a data capture standpoint, it will not be nearly as helpful as it otherwise could have been. So my dream world, I would love for us to be able to have a universal understanding of the importance of the process of actually capturing this information and how critical it is to drive patient care and outcomes.
Generational.
Andy just introduced our next topic for our next blab. We'll have to talk about healthcare data quality. How do we make sure it's reliable? How do we make sure it's consistent? And all of those things. So I want to wrap up this for the YouTube audience that's watching on the replay. Thanks everyone for joining live. Thanks for watching the recording. You can find other great videos at healthcarescene.com. Big thank you to Mandi Bishop, Health Plan Analytics Innovation Practice Lead at Dell, and Ashish Patel, the co-founder of careset.com and docgraph.com. Thanks so much, guys.
Bye.
Thank you very much. Bye-bye.